Hi, Rajeev, Pathak, and Mike Gibson coming to you live from AHA 2024, and we're talking about the REST trial. We often don't think about risk factor reduction in these cases that you do in electrophysiology. Talk to us a little bit about what you did and what you found.
Thanks, Mike, for the invitation, and it's a pleasure. So I'm really excited to present the results of our ARREST-AF randomized controlled trial. So, Mike, catheter ablation is an established therapy for drug-refractory atrial fibrillation. It has multiple studies have shown the benefit. However, as we look at the results, we see that success, there is an attrition over the time. We see what is successful in the first year, and slowly we start seeing the recurrence. Now, this could be because of the pulmonary vein reconnections. And we know that there are pulmonary vein reconnections which results into recurrences. However, there are studies which have shown that despite doing a solid pulmonary vein isolation and there is no reconnection, we see the substrate continues to evolve. And then there are Australian study from John Kalman's lab where we have seen that despite no atrial fibrillation, the substrate continues to progress. So that led to our hypothesis that this is, the cardiac risk factors which may be responsible for that. Now, we know from observational data and large population-based data that risk factors are responsible for atrial fibrillation. And there are studies which have shown that isolated risk factor management have shown some benefit even in reducing the recurrence of atrial fibrillation post-AF ablation. Now, our own observational data, which was the legacy study and cardiofit study and ARREST-AF, the cohort study, which was the beginning of all this, where we looked at management of these all risk factors and looking at the impact of these on the recurrence of atrial fibrillation. And that we found that if you manage these risk factors, there is a trend towards improvement in ablation outcome. And that really did result into us designing this study because there was no randomized control data looking at management of all the cardiac risk factors and then what implication it will have on the recurrence of atrial fibrillation. So we hypothesized that if we manage these cardiac risk factors really well, the ablation outcomes are going to be better because there'll be less evolving substrates in these patients. And therefore, what we did was we designed a multi-center randomized controlled trial where the patients were followed up for 12 months, and at the end of the 12 months, we were going to look at the AF recurrence in the arm. The patients were randomized in one-to-one fashion to a physician-led, tailored, goal-directed lifestyle and risk factor management group, or the other group were going to be the usual care group. Okay, so these were the two groups. The usual care group, when they came for the initial consultation, they were also given advice regarding what should be done and how should they manage their risk factors. However, they did not attend a goal-directed, physician-led, tailored clinic, and 3 monthly visits and goals were given for achieving, and help and assistance was given to these patients. So these were the two groups of patients. There was no difference in how their AF was managed. That was based on the guidelines, and both those subset of patients got exactly same treatment. Additionally, these patients had a loop recorder implanted at the time of randomization so that we can actually see the real recurrence. And additionally, we did quality of life questionnaire. We looked at how their risk factors were managed, and these were our primary and secondary outcomes.
And what did you find?
So what we found was, really great. We had 60 patients or 62 patients in the risk factor management group randomized and 60 patients in the usual care group. And what we found was that at 12 months, 61% of the patients in the risk factor management group has had no recurrence whatsoever, no atrial arrhythmia recurrence. Whereas in the usual group, we had only 40% of the patients who were free from any arrhythmia whatsoever. So we had quite a dramatic difference in the AF recurrence between the two groups, and that was our primary endpoint. We also had a few other secondary endpoints. We were looking at quality of life and AF burden and a symptom burden, and that was through AFSS Canadian questionnaire. And what we found was with risk factor management, not only they did not have recurrence, the symptom burden, the arrhythmia, how they felt also reduced quite significantly. We saw a positive impact on their cardiometabolic profile. So they had good weight loss, and roughly the weight loss was roughly around 7 kilos weight loss in the risk factor management group. They had a better blood pressure control, a better lipid and metabolic profiles were seen. So these were our other secondary findings. We also saw left atrial index volume were reduced in patients with aggressive risk factor management. I guess with the weight loss, there was a positive reverse remodeling of the atria, which was seen.
Wow, we'd only have to treat 5 people with aggressive risk factor modification to prevent one recurrence. That's amazing. And, there's so much emphasis these days on obesity management and weight loss. The number is kind of staggering. Somewhere between 6 and 16% of Americans are on a weight loss drug now. So I said, I was speaking at TCT, and I said, I think we may see an impact on atrial fibrillation. And people
Yeah.
kind of poo-pooed it, but I think we might. What are your thoughts?
Well, look, I most certainly think there are many large observational studies which have shown that cardiac risk factors are responsible for atrial fibrillation. There is a shift in the almost a paradigm shift, I must say, in last 10 years in how we now see the atrial fibrillation as almost as an end organ damage because of the risk factors. At least the subset of patients, and not everyone will have that. There are certain subsets with almost zero risk factors that we know of. They may not have a cardiometabolic risk factor. They may have other risk factors, which we may be identifying as the time goes on. But there are certain subset of patients with cardiometabolic risk factors, and those are responsible for fibrillation in these patients. And then these patients get ablation. If you don't manage the risk factors, you see the recurrence. We have seen observational data, small randomized data, and our data most certainly, again, proves that, or almost has a really conclusive evidence here from the study showing there is, in a randomized fashion, if you deliver it well, we still see a significant big difference.
Wow, well, congratulations, Rajeev. Great job. Great study. Thanks for
Thank
joining.
you.
Thanks to all of you for joining us here live from AHA 2024.
Thank you very much, Mike. It was a pleasure.